Hello, hi wonderful people. This is your girl Nancy and welcome back to LovelyyOT channel. Okay, today we are going to talk about one of my favorite things to do on here, which is to teach. Today I'm going to do a little LovelyyOT class on Parkinson's. Okay, Parkinson's is one of those disorders that I often see in my patients. Let's talk about the pathology behind Parkinson's. Okay, so Parkinson's is a neurodegenerative disorder, okay, which basically means that the disorder is in the brain. Okay, there's something wrong with the brain, somewhere in the brain. Okay, and degenerative weird sound going on in my apartment. I'm like, what's happening? And degenerative basically means that once you get the disorder, you basically get worse with the disorder. Sometimes you can maintain for a couple of years, but usually, more commonly, patients usually decline once they get the disorder. Scientifically, or if you're looking at the science, the pathology part of the disease, so this part of your brain called the substantia nigra. This substantia nigra is filled with dopamine neurons, okay? Which dopamine, if you know dopamine is basically like your happy neurons, your pleasure neurons. So your dopamine neurotransmitters usually send whenever you are in pleasure or if you're happy or anything like that, your dopamine neurotransmitters usually send the chemicals down to your brain to be able to feel those pleasure things or those happy things. So research have found that people with Parkinson's, when they checked the brain, specifically the substantia nigra part, had less dopamine neurons in the brain. So obviously there's a connection there as to why the Parkinson's is happening. Okay, whether it being the lack of the neurons, the dopamine neurons, or there is a decrease in the dopamine neurons. Okay, another part that is also affected in people with Parkinson's is the motor cortex of the brain. So your motor cortex is basically the part of the brain that allows us to be able to do, to act, to perform. Okay, the fact that I'm speaking, I can eat, I can swallow, I can move my hands, I can do all of these different actions is because of my motor cortex. So obviously if my motor cortex is being affected by Parkinson's, then we can conclude that the motor cortex is affected, therefore doing things is going to be a lot harder for someone with Parkinson's, right? Am I right? Okay, right. So it's not able to send down the messages to the body for the body to be able to take the actions that they want to take. So initiation can be very difficult for them. Motor planning is very difficult for them. Things of that nature. For some reason, the quality of movement is also affected. So for example, if the patient is able to speak, if the patient is able to swallow, able to do things, walk, sometimes for some reason everything kind of slows down in a way, which I thought was very interesting. Also, there's a gradual loss of functions with people with the Parkinson's. So the gradual loss of function would definitely be from the motor aspect, okay? The motor functions, being able to do things voluntarily and involuntary. So the voluntary movement and the involuntary movement will be affected. The slowdown of movement is termed as bradykinesia, which basically means slow movement. Slowness in the execution of things, slowness in thinking things, slowness in basically a lot of different areas in their daily activities is going to be slowed down. So obviously if everything is slowed down, then that means that if a patient with Parkinson's, when they are completing a self-care, you should expect that this patient is going to take some time. They're going to need increased time to be able to do whatever they're doing because the connection is not there as someone who didn't have Parkinson's. Okay, so just keep that in mind when working with someone with Parkinson's. So sometimes these patients may know, we're guessing that they may know what they want to do. So for example, I want to stand, right? I want to eat, I want to do that. However, they're not able to initiate it because the brain is not giving them the input that they need to be able to take those actions. So they may feel like doing something, feel like standing, feeling like doing that, but they may not be able to actually carry through those actions, which can be, obviously, I would think, can be very frustrating. Okay. Another thing that you can definitely see with someone Parkinson's is resting tremors. Another thing that you can also see is rigidity, which basically means stiff movement. Okay, those freezing movement that you have probably seen in your textbooks. I've seen it in real life, like literally in the middle of doing a transfer, in the middle of walking, the patient can literally freeze and forget, especially when you're turning corners and things like that. They can forget, or they just freeze, and they are not able to initiate the next movement, and that's because of the disconnect from the brain to the legs or to the arm. This rigidity also affects smooth movements, like I already mentioned before. This patient may not be able to do like the fine motor skills activities any longer. It may be super difficult for them to do like anything that's very fine, very smooth, even if it's walking very smooth, standing very smoothly. They're not able to do this because of, if they're doing something, they can do it very like quickly, very like gross motor like, very unsafe obviously. So just keep all of those things in mind when you're working with someone with Parkinson's. Okay? So the freezing, the term for the freezing is called akinesia. Okay, that's when they freeze. They kind of doing something and then they freeze in the middle of doing whatever it is that they're doing, because the brain cannot make the connection. Okay, and so therefore, obviously, if I need my brain to tell me to talk, to be able to talk, I need my brain to kind of connect to my mouth for me to talk. And the brain is not doing that. I'm probably going to be like, and forget. And not that I forget, is that I can't, because there's no connection there, or the connection is slower than normal. Okay, another symptom that is mostly common with people with Parkinson's is also dysphagia. Okay, so dysphagia is basically issues with swallowing, and they're also more likely to experience choking, okay, and aspiration. So make sure that the speech therapist is also included in the care plan or the plan of care, or so that they're able to provide assistance as needed. Okay. Another thing to expect is definitely dysarthria. Okay, dysarthria basically means that there is a slowness in speech. Okay, so like I said, everything will slow down, so it's not far-fetched that speech will also be slurred and a little bit on the slower side. Expect constipation, expect incontinence, okay, because there's a loss of control of their bladder. Okay, they're not able to control their bladder, and the reason why they have constipation is because, once again, what allows us to be able to poop and fart and all of those things is your motor cortex. All of those things that we do that we really don't think about, our body is able to do because of the function from our brain telling our body what to do. And because there is a dysfunction in the motor cortex, their poop, so to speak, does not know when to feel those feelings that will make you want to feel like you need to poop, for example. And then there's no control over the bladder to hold in place the pee. Okay, so expect that to be a problem as well. Another thing to think about is definitely endurance and fatigue issues. Usually people with Parkinson's get tired very quickly. Okay, so endurance activities is definitely something to think about when you're working with someone with Parkinson's. You may also see some emotional disturbances, some behavior changes as well. So once again, connect it all back to the brain. Once a part of the brain is affected, it's like the whole shebang is just going down the drain. And so that's just what comes along with it. So delusions, hallucinations, all of those things. Posture will be affected, like I already mentioned. Balance is going to be affected. Cognition is definitely a huge thing that will be affected by Parkinson's, and I see this on a daily basis. I actually have a patient who does have Parkinson's right now, and his cognition is really poor. Once again, obviously the brain is damaged and there is a dysfunction in the brain, so cognition is not a far-fetched idea that cognition will also be affected. So definitely, in terms of the cognition, then we're thinking about the attention span has been limited, and also being able to keep focus on something for a long time is affected. Okay, and definitely thinking and processing information would definitely be a lot slowed, so a lot slower than normal. So a person with Parkinson's would take a longer time to kind of, if you do ask them a question, they may take a longer period of time to like think about what they're going to say, or take a longer time to respond to what you're asking them, because their processing is just been slowed down because of the lack of the dopamine neurons. So unfortunately, there is no cure for Parkinson's, okay? And once you are diagnosed with Parkinson's, it's definitely a gradual thing, right? So you may not see all of these symptoms in like right when you're being diagnosed. You may not see all of these symptoms. It's definitely something that you will see as the disease progresses along. So just keep that in mind. So what are some of the things that we can do for patients with Parkinson's? One, the goal should always to be to maintain the strength and the endurance, and maybe even some of the cognition that they have, to be able to maintain that for as long as possible. To also slow down the progression of the disease is definitely one of the goals for therapy, right? Can we slow down the progression of the disease by being engaged in different therapy? And can we maintain what's already there, or what has been gained through therapy? There's definitely medications out there for people with Parkinson's in relation to getting more dopamine in the brain. So different medications are definitely out there. I've heard that there's also brain stimulation type of things that are out there, but that's not obviously not therapy related, right? So what we can do in therapy is definitely exercises, right? That's one of our things that we do to definitely to maintain strength and also to gain strength, right? So gain as much strength as they can possibly gain, and to be able to maintain that strength that they have gained, so there's not a quicker loss of strength, okay? Definitely working on flexibility, balance, you know, the normal things that you work on anyway, based on that particular patient's symptoms that they are showing at that time, of course. Another thing that you can also definitely do is massages. Massages are great for muscle relaxation. Like I already mentioned, a lot of people with Parkinson's have resting tremors, okay, and they also tend to be very rigid and very tight and very stiff. So massages can decrease all of that and increase the relaxation for the muscles. So definitely incorporate that into your treatment sessions. Use of rhythm is definitely something to also think about. I use rhythm a lot when I have someone with Parkinson's. It really works a lot. I don't know what the connection is. I need to do more research about how auditory and rhythm movement and stuff like that is, you know, working with for people with Parkinson's to unfreeze them, especially when they are walking and they get to like slow down their movement and they get a little stiff and they're doing the shuffle feet and the little freezing movement when you're doing auditory. So usually what I do is when I'm walking with a patient, for example, I would do like the snaps, right? Or I would do a clap, like clap, 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 and that kind of rhythm for some reason kind of clicks in the brain, and they're able to move at a more normal pace than if they're doing it without any kind of rhythm or tapping or anything like that, okay? And I think there's apps out there too to help with this if you're having a problem doing it yourself. Okay. And obviously if you're working as an occupational therapist with someone with Parkinson's, definitely going to be working on increasing their self-care independence. So allowing them to be more independent, allowing them to do more ADLs themselves, so instead of doing it for them. And like I've already mentioned in numerous of my videos, if you are going to do it for the patient, it's no longer considered therapy. Like that's not therapy if I'm doing it for you, right? So always allow the patient to engage, even if they cannot do it like totally independent. At least allow them to do something, to try to initiate. Absolutely, you can give them cues, auditory cues, visual cues, tactile cues, any kind of cues that you feel like that patient needs to be able to be more independent is definitely needed. Because one thing to also remember is that when you a baby, for example, right? You learn certain things as you're growing up, right? And then when you get to a certain age, certain things kind of come to you automatically. You don't really think about brushing your teeth or how to brush it anymore. You don't think about how to comb your hair, how to dress, how to walk. You don't think about stuff like that anymore because it has become automatic to you. So you can do it automatically. Your brain has already programmed how to brush your teeth, how to walk, how to eat, and all of that stuff is already programmed into your brain. Now, when you get diagnosed with a disease such as Parkinson's, which is affecting your brain, what happens is that it's almost like your brain erases some of the automatic movements, automatic things that you used to do. And so this patient has to now relearn some of these things that used to come very automatic to them. Now they have to relearn how to do their hygiene, how to do their self-care and things like that, to basically try to build different pathways or to also use different ways to accomplish the same task, so to speak. So making sure that you kind of establish different strategies and different ways in order for them to be able to engage in your self-care, that's like a no-brainer. Like, you have to do that as soon as possible, as soon as you can, so that they'll be able to establish some kind of routine, and then that can have them be more independent for a longer period of time. So for example, if you're teaching them how to do sit-ups, for example, so going from sitting position to standing, for example, you want to make sure that you include like specific strategies, like, hey, nose over toes, like put your arm on the armrest and push up from the armrest, those kind of auditory cues to allow them to kind of relate that to standing up, if that makes sense. So every time he or she is going to stand, every time they're going to stand up, they're going to be thinking about hand on their armrest, nose over toes, push your butt up. Like, so those things, you should definitely integrate that into your treatment, so that it can become almost like the new norm for them to be able to engage in those activities they want to engage in. Think about if they're going to be home with a spouse, alone. Think about home modification. Think about safety. You also can definitely do a lot of caregiver education with the family, with the spouses, the partners. Energy conservation skills, that's another no-brainer, because absolutely every time I have a neuro patient, Parkinson's, MS, ALS, all of those different diagnoses, I always work on energy conservation skills with them, because it's inevitable. Like, a lot of these patients will have an issue with fatigue and being weak and having low endurance, low activity, and activity tolerance. So doing some kind of energy conservation education with them, or energy conservation, there's different things that they can do to kind of conserve their energy, so they be able to do the things that they want to do. So important, because they're definitely gonna need that, and they're gonna be tired a whole lot. So just remember that. The last thing that I want to mention is the big therapy. So it's widely researched. It's called the LSVT, big therapy. Okay, and basically what it means in a nutshell is that for some reason, like I said, fine motor skills and smooth movement is not going to be the thing for people with Parkinson's. So when you are teaching them skills, like bed mobility, like doing sit to stands, functional mobility, make sure that you're doing it in big movements, right? So like really throwing your arms over, really pushing up, like doing it in very like large gestures and very like gross motor like movement. For some reason, there's a lot more carryover when you do that versus doing it very fine, because obviously, going back to PEDS, right, when you're younger, we usually learn doing the bigger things before we learn doing the smaller things. So usually kids can, like, when you give them a pen to draw, for example, they will draw like big marks all over. If you have kids, they'll draw over the walls, they'll draw over, like, they would do things like really big, and that's because they haven't refined their very fine smooth movements yet, because that comes later on. So of course that's what's going to go first. So the fine movements usually go first, so concentrating using their gross motor skills to teach them how to do different things is definitely something to research into and look into. I think you may need to get certified or get some kind of training to be able to do it correctly. But it's definitely, there's a lot of different research out there in regards to that specific topic. So I'm going to leave the link below for you guys if you want to check that out. Oh, and one last thing that I want to add is that make sure that you guys remember and keep in mind that all of the interventions in regards to PD, Parkinson's, is to improve the symptoms. Like I already mentioned before, to slow down the progression of the disease. None of them is supposed to cure the disease, okay? So just make sure you keep that in mind when you are treating your patients. And as always, please make sure that you like, comment, and subscribe. And follow me on LovelyyOT _ Lovely with 2 Y's _ OT on Instagram. And I will see you guys in the next video. Thank you so much. Bye.